So good morning, everyone, and thank you for joining us for what is actually our first symposium of the day, although there are concurrent sessions going on at the moment. My name is Gretchen Navidi. I'm with the NIMH, and we're very pleased to have all of you here with us. This particular session is titled An Evidence-Based Approach to Mitigate Suicide Risk in Adolescents During Transition from Inpatient to Outpatient Care. We will have several speakers during this 90-minute session. And really, I want to turn it over to Dr. Betsy Kennard, who will chair the session. And let's move on from here. Thank you.
Thank you, Gretchen. It's an honor to be here today, and wanted to just kind of give you a little background of why we're here and what we're talking about. I'm Betsy Kennard, a professor in psychiatry at UT Southwestern in Dallas, Texas, and was fortunate enough to be one of the sites for the NIMH treatment of adolescent suicide attempters, the TASA study that was chaired by Dr. Brandt and run by Dr. David Brandt, who's our discussant today. Soon after that study, we began to see more and more suicidal events or kids with suicidal events in the emergency department at our children's hospital, and really decided we needed another level of care in addition to just inpatient and outpatient. And we developed an intensive outpatient program, again, a collaboration with Dr. David Brandt's group of the STAR Center, who generously helped us get that started. And we'll be talking about that today, as well as our attempts to try to take those treatment strategies into the community to try to implement and disseminate some of the strategies that we've learned through TASA, the STAR Center, and our IOP into the community, and we'll be talking about that as well. And finally we have a bright dissertation student with us who is translating the Tom Joyner's interpersonal theory of suicide into a clinical intervention. So we'll be talking about those components today. Again, we're proud to have Dr. Brandt as our discussant. And we're going to start out with a recent study, again, a two-site study funded by National Institute of Mental Health and R34 to Dr. David Brandt and myself, with Tina Goldstein and many people from the Pittsburgh group. We have a big, large co-authorship, and I've listed them at the bottom, but there are too many to go through one by one. Again, funded by the NIMH. We just completed this study at Pittsburgh and Dallas. And the study was approved by the IRBs at each site, and we had a very talented data safety monitoring board between the two sites with experts in suicide, both at Pittsburgh and UT Southwestern. So the goal for me today is to talk about the intervention that we developed to prevent discharge attempts after leaving the hospital, to describe an app that was supporting the intervention, a phone app, and to report on our outcomes as well as feasibility and satisfaction. So the reason this study was developed is because, as many of you know, that there's a high critical period, a high rate of reattempts post-discharge from the hospital. This is true in adolescents as well as adults. And there's often a big gap between the discharge from inpatient to actually accessing outpatient care, which we feel increases the risk. And then even with outpatient treatment, that post-discharge period, early care, often is still a high risk for reattempt even with treatment, which led us to wonder, are they getting enough skills early on? Is there a dosage issue that we can increase the dosage of these strategies to prevent risk, to prevent reattempts? So our idea was to do a brief intervention on the inpatient unit that we hoped would be protective against attempt after discharge. So we compared the ASAP intervention, as safe as possible, with treatment as usual. With treatment as usual on an inpatient unit primarily being a stable safety plan. They do get some group therapy, skills group therapy, And their goal is to leave with referrals and get them to outpatient care. What we added to TAU was several components. We added the chain analysis, which we'll talk about, which is a functional analysis of the index event leading to the hospitalization, a safety plan based on that analysis, strategies basically to access interpersonal support as well as crisis support. We added distress tolerance modules, emotional regulation, and throughout the intervention, we did a motivational interviewing component, which was really kind of spearheaded by Dr. Tina Goldstein. So just briefly about the app, we had on the phone, we basically personalized the app, but we started with reminders to rate their mood. So they would rate their level of distress, how they felt right now. We would talk with them and collaborate when those ratings would occur on their phone, when they would get prompted to rate their mood. And then we had several options for them, again, based on the chain analysis on the things that were helpful to them. So we had reasons for living, savoring, which I'll talk a little bit about more, ways they could distract themselves or soothe themselves. Reasons for living was very important, as well as reaching out to contacts. They all could be personalized, so they could use photos, there could be websites that they really liked. There may be some that liked mindfulness, some that liked meditation, some that liked deep breathing. We would put those sites on their app in a collaborative manner. And then after the activity, they would re-rate their mood and rate how useful the activity was and re-rate the distress post-intervention. So this is I'll try to make this brief. This is a little bit about the manual that we used. Again, want to very much emphasize that motivational interviewing was a huge part of this intervention, and it was the framework for every module that I'm going to discuss. We were really working on adherence both to the skills, but also kind of working with them to make sure they got into outpatient care, and I'll talk more about that too. We did psychoeducation about risk factors and protective factors, both with the children and the families. And we talked with the families on helpful communication at home, avoiding high conflict, ways they can decrease conflict and talk about things that are conflictual after they've calmed down. We also worked on a safety plan that was really derived from the chain analysis, which looking at vulnerabilities, cognitive factors, behavioral factors. And that chain analysis helped us to populate the phone app as well as to develop the safety plan. And the safety plan we would go over with the parents. We also had a big behavioral activation component, reasons for living, mood monitoring, and pleasant activities. So we would also begin to introduce the app. We would have it not on their phone at this point, but have it on a tablet that we could bring in and out of the inpatient unit. We would tie reasons for living into the safety plan, as well as mood monitoring and building positive affect through pleasant activities and savoring, which I'll talk about in just a minute. And then at the end of the session, we'd talk about what skills were helpful and what that we might put into their safety plan and into their phone app. Dana McMakin, who was at Pittsburgh, now in Florida, was very helpful in sharing her work on savoring, which is basically getting access to positive affect through visual imagery and memories of past positive experiences. We also taught them how to, when they were in a ruminative negative cycle or about negative events, how to switch into the positive savoring. And we also had distress tolerance, skills for relaxation, self-soothing, and again, how that fit into the app. At the end, we would do consolidation. We review what was helpful. We would troubleshoot what barriers might they have to using the skills, what barriers they might have to using the app. We would be talking to them about access to outpatient care and plans for case management. We also scheduled and let them know we would be calling them for bridging calls. Those were helpful, particularly around the app if there were problems with the app, or if there were problems getting to care or using their skills. We had the option to really work with them on those. And then our goal was that when we could, we would try to liaison with those providers that were following these kids in outpatient to discuss what our experiences had been with them, let them know about the app and the skills that were taught in the inpatient unit. We had a QA system where all of the sessions were recorded, and we rated around 20% of those. We had those that were expert in the different areas to rate those particular components, and we rated as over 80% of all were we've considered very adequate. This is really busy. I won't go into too much detail, but just to let you know that we randomized basically after, we screened them for appropriateness. We randomized to ASAP and also to treatment as usual. So 34 in the ASAP group. Is that right? No, 34 in the ASAP group and 32 in the treatment as usual. There were no differences in attrition between the groups. We did assessments at weeks 4, 12, and 24 to assess for events as well as some of the suicidal ideation and some of the other measures that we use that I'll talk about. We did randomize based on or balanced on sex, previous attempt, drug and alcohol use. And we found that the sites were really pretty similar, except for our site in Dallas compared to Pittsburgh was a little bit younger, a little higher income, and more likely to live with both biological parents. Not unusual for us because we've done things with Pittsburgh before. We tended to, in Tordia and Tessa, look a little different as well. We did not find any differences in demographic between the treatment groups. I will say in this particular sample, it was mostly female, almost 90% female across the two groups, mostly Caucasian, and most had had a previous attempt, and most had a history of NSSI. So very, pretty ill sample. These are to show, again, the difference between treatment groups based on some of our other measures, the PHQ, the anxiety measure, the scared, physical sexual abuse, reasons for living, and emotional regulation. Again, no differences between the two groups at baseline. Here are our outcomes at 6 months. We did not see a difference on suicidal ideation or the other measures, and on suicide attempt it was not statistically significant, but the effect size was significant at 0.47. With the TAU group, this was in the 6-month period, almost 30% of those in TAU had an attempt post-discharge, whereas 10% in the ASAP group. There was a difference in time to attempt, with the ASAP group having a longer time to attempt than those in the TAU. And then we also found that there was a moderation by history. So those with a history of past attempt tended to do better with the intervention, which we were actually kind of pleased because we had built this intervention for those that were most at risk and were in high need of additional care. I will just comment on a couple of additional findings. There was an increase in social support in those that got ASAP over time, which we were pleased to see. Don't know if that was related to the app or not. We didn't have that capability, which I'll talk about in a minute. We also found, I will say this, we had some difficulty catching families on the unit, engaging families. That's something when we do our next study we need to look at more carefully. What we did find is those that had at least one or more family sessions or family involved in the treatment tended to have lower suicidal ideation over time, which we think is significant and something that we need to address in our next study. Service use after discharge between the two groups did not differ significantly, except for one particular finding that was a little bit of a puzzle to us, was that there were fewer people in the ASAP group that accessed outpatient care after discharge. We feel like that might be related to them feeling like they got a sufficient dosage of skills with the intervention that we did. We don't have That's a hypothesis. We don't have the ability to say whether that is true or not, but that was something we weren't expecting, but was a difference. Talk a little bit about the app and the use of the app. We were not sure. There were people that said to us, kids aren't going to use the app, or they will use it a few times and not again. But really, we found a good percentage did use the app, and quite a few times. In terms of most rated their mood, and well, about a little less than 50% actually used the crisis contacts, and then about a median of about 19 times they rated their mood. So we felt like the use of the app was good. We were pleased with that. What we didn't find, which we had hoped to find, but again, the sample size was really small. We're talking about 34 kids at this point. Relationship between the use of the app and suicidal outcomes. We didn't find significance in attempt or ideation. However, we did find that those that rated their mood more frequently tended to have an increase over time in reasons for living. So that was something that, again, we hope to be able to see what's going on there with a larger study. We got feedback about the intervention. We used the client satisfaction inventory and did find, while the p-value, again, is not significant, pretty good effect size for the ASAP group being more satisfied than the TAU group. We had, just to mention a few of the things that the children said, but the one thing I liked was that they could say some skills, like they talked about the emotion thermometer, they talked about grounding, they talked about mindfulness, they talked about distraction or things that bring them joy, like writing, painting, and even mentioned tolerating distress, which we were glad to see. The computer usability satisfaction questionnaire, this is also an instrument to rate the usefulness of technology. Again, the ratings were very good over time. This is just for those that had the app, so there's no between group differences, but they, even up to week 24, seemed to be satisfied with the app. The quotes were very, I thought, very important. One said, I've used guided imagery. It's really helpful for me when I can't sleep or when I have a panic attack. One said, it helps me focus on the good things. When I felt a little suicidal, I could focus on things that made me happy, like the people in my life and goals. The last one, I really liked how you check in with yourself. Your temperature's rising and you don't even know it. You can stop and check in. I started doing it without even the app. It became natural to me and it helped a lot. So briefly, just to kind of conclude, we did have limitations. Obviously, it's a very small sample size with limited power. Our sample was largely female and Caucasian, which limited our ability to generalize to other populations. We didn't use structured diagnostic assessments. We wanted to make this, since the inpatient units can be kind of busy, chaotic, we did use a self-report and clinical diagnoses. We also, as I said earlier, we had difficulty engaging families in the intervention during the hospitalization. Our group is going to be meeting to discuss that as we go into the next study to see how we can do better on that. And also we should note that our design does not allow us to determine what components of the intervention are better. Was it the app, was it the intervention, or was it the combination? So just to conclude, we found that the app and the ASAP intervention was a feasible combined treatment to bridge from inpatient to outpatient care. We found that both the intervention and the app were very acceptable. We found that the rates of suicide attempt were lower in those that got ASAP and Bright. There were no main effects on the intervention for suicidal ideation. However, our focus was primarily on attempts, so it was not that big a surprise. We just really wanted to reduce risk for acting on suicidal urges, which we feel like we were successful in. The intervention also appeared to impact support, which may be related to lower attempts. We'll hope to be able to look at that more closely in the next study. And participants whose families received at least one ASAP session tended to have lower suicidal ideation over time. The patients had lower suicidal ideation. So Dr. Brandt and his group and our group were able to get funding from the American Foundation for Suicide Prevention for a larger study. So we're going to do a design with a 2x2 design to see if we can separate the different components in the intervention, the combination as we tested before, and Bright alone, ASAP alone versus TAU. And we're hoping to make it a dissemination study training inpatient units in the intervention. I'd like to acknowledge the people at Pittsburgh as well as UT Southwestern, and also Jane Pearson and Joel Sherrill, our program officers. Dr. Sherrill is here, which is great. Our inpatient staff helped us a lot. Patients and families, we're very grateful to them and our departments. And I'm going to turn over. I would like to say we want to make sure to get through all the talks and have time for Dr. Brandt, so we are going to save questions till the end. And I'm going to introduce Dr. King completed her PhD in clinical psychology at UT Southwestern Medical Center in Dallas in 2016, and her postdoctoral fellowship in clinical child psychology at Children's Health. She focused on treating depressed and suicidal youth, and in 2017, she was hired as a faculty member at UT Southwestern and Children's, and she is in our IOP, again, that we collaborated on with the STAR Center, and she's currently involved in the IOP and clinical development of programs.
Well, nice to be with you all today. I'll be talking about Spark, which is Suicide Prevention and Resilience at Children's. It's our intensive outpatient program at Children's Health in Dallas, Texas. So my objectives are to talk about the development of Spark, and then to talk about our initial outcomes for the first 2 years of the program, 2014 to 2016. Then I'm going to briefly zoom into a particular study we did looking at changes in suicidal ideation over time with our sample. And then I'll step back out and talk about future directions for Spark. Okay. So in 2018 to 2015, there was a study across 32 children's hospitals, and the rate of encounters for suicidality and self-harm doubled, so increasing from 0.67% in 2008 to 1.79% in 2015. And these visits were particularly high among adolescents 12 to 17. As Dr. Kennard said, we know that risk following discharge from a psychiatric hospitalization is particularly high, especially in that 1 month following discharge. And we know that linkage to care and an adequate dosage of treatment is really important to mitigate suicide risk. Yet, many adolescents have limited outpatient care following hospitalization, 4 to 6 outpatient visits on average, and many are non-adherent to outpatient care. Yet there are many promising interventions for adolescent suicidality that include distress tolerance, emotion regulation, and safety planning. So at Children's Health Dallas, we saw similar trends to what I just spoke about nationally. In 2009, we had 300 encounters in the ER for suicide and self-harm, and that more than tripled in 2014, where over 900 encounters were related to suicidality and self-harm. And the issue is there are limited services in the community who could really take care of these children. So in comes Spark. Spark was developed to meet the high need in of the suicidal adolescents in the ER. And there's several advantages. So it provides more robust services than traditional outpatient therapy. IOP is intensive by nature, 7 to 9 hours of treatment on average. Lower cost than inpatient hospitalization, and it allows the child to remain in home in their school, so they can really generalize skills and safety planning to their day-to-day environment. So the goal with program development is to offer intensive treatment during that really vulnerable period post-hospitalization or post-event, whether it's an attempt or increased suicidal ideation, and to really target risk factors that we know can be characteristic of teens with suicidal behaviors. And we did that through CBT and DBT strategies. So our program director, Dr. Kennard, and the Spark team visited the established program services for teens at risk, the STAR Center at the Western Psychiatric Institute in Pittsburgh. The STAR Center is funded by the Pennsylvania General Assembly and is in over its 30th year of developing and disseminating best practices for prevention and treatment of youth suicide. So Spark was modeled after the STAR IOP. And this happened through visits to the STAR Center, resource sharing, consultation, and then collaboration on ongoing clinical trials, such as Dr. Kennard just discussed. So some unique components of the STAR program that we emulated at Spark is that it's non-diagnostic. Many IOPs in the community tend to be focused on depression, for example, but this is more non-specific related to suicidality and suicide risk factors. At both programs, there must be an event, either increased suicidal ideation or an attempt, and it really helps to bridge the gap between inpatient and outpatient care during the most vulnerable time. We begin treatment with a chain analysis to look at vulnerabilities and perpetuating factors of the event with increased suicidal ideation or attempt, and that really helps guide treatment throughout. Okay, so in the development, Dr. Kennard co-wrote the manual with the Spark therapist. The therapists got together and practiced modules in group with simulated patients. And the manual is an iterative process after receiving feedback from stakeholders, including adolescents and their families and clinicians. This included observation of staff and then the development of QA ratings. And this is something we have implemented currently, and about 10% of our groups are rated for quality assurance. So the components of the program include teen group. That's twice weekly for 3 hours, and there's 12 core modules we go through based primarily on CBT but also DBT. So some examples of modules include distress tolerance, emotion regulation, and mindfulness. There's a multifamily group, which is new. We added that in February 2015, and it's skills-based based on bolstering family communication and orientation to the program, and that's twice during adolescents' stay in the IOP, and IOP is about 4 to 6 weeks on average. There's parent group once a week where parents learn the skills the teens are being taught and also have a chance to get support from other parents. Individual therapy where treatment is really tailored to the teen and they apply, talk about the skills and how that applies to their daily lives. And then last but not least, medication management. So several of our teens are seen by psychiatrists in the community, and their meds are evaluated by our psychiatrist, and if needed, consultation happens. And there's many teens we see who do not have a psychiatrist, so they'll see one of our psychiatrists through the depression clinic at Children's Health, and we have ongoing collaboration with them. So from 2014 through September 2016, there are 415 adolescents assessed. 51 did not enter primarily because a lower level of care was sufficient, and 364 entered Spark with 295 completing the program, which is an 81% completion rate. Here are the key measures that we gather from teens pre-treatment and post-treatment. So one is the concise health risk tracking. This was validated in adults primarily, but there's just a study that came out by Mays and colleagues in the Journal of Affective Disorders validating this in an adolescent sample. So it's looking at suicide risk, which is a measure of active suicidal ideation, and it's 3 items on a 5 Likert scale, and then propensity, which is those cognitions we think of being related with suicidality, such as despair, hopelessness, lack of perceived social support. We also administer the quick inventory of depressive symptomatology to adolescents and their parents, and it's based on the DSM-4 criteria for major depressive disorder in those 12 and older. And then lastly, the clinician administers Columbia Suicide Severity Rating Scale to assess current history of attempt, lifetime history of attempt, and non-suicidal self-injury. And here's just briefly the questions on the risk subscale. We find this to be very helpful. It can be sensitive to changes in suicidality over time. Okay, So we also conduct a follow-up call at 1 month and 6 months to the patient and their family, and we assess any subsequent suicidal behavior, service utilization for suicidality, such as was there an inpatient hospitalization or an ER visit post-discharge from the program. And then we also check on their adherence to ongoing psychiatric and psychosocial treatments. So of the 364 patients entering Spark from 2014 to 2016, the mean age was 14.9. They're primarily girls and non-Hispanic Caucasian. There's a high rate of lifetime attempt at 67.9%. About half of the teens came from IOP for increased suicidal ideation that warranted a higher level of care, and the other half came following a suicide attempt. 73.4% had lifetime in SSI, and the average number of groups attended was 9 in over a 5-week duration. So here, a lot of information here, but these are the primary measures I discussed earlier. So you can see briefly the QIDS. Adolescent was in the moderate range at baseline, and that decreased to the mild range at discharge. The parent report followed a similar trajectory. For the CHRT propensity, those cognitions associated with suicidality, greater than 21 is considered to be at risk. And so the initial propensity was 26.27 on average. It decreased to 16. And then CHRT risk greater than 3 is thought to be at increased risk. People are endorsing active suicidal ideation at that point, and that decreased to 1.89. So the takeaway from this is people got significantly better in terms of depressive symptoms, propensity, and risk, yet they're not completely well. And so one really important component of our program is linking our teens to care to make sure they're continuing to receive services when they're done with IOP. So of the 364 enrolled, 286 completed the 6-month follow-up, which is 78.6%. 8.7% had an attempt within the 6 months following discharge, and 27.3% had an event. So that could include attempt, but it could also include psychiatric hospitalization or ER visit. So we would expect the event to be higher than the attempt, of course. And some of this might be due to adolescents following their safety plan. So when adolescents exhaust their internal coping resources and reach out to support within their family and community, the next step is seeking professional help. So that could explain the percentage of events. So how do we compare to other trials and treatment programs? So TASA, treatment of adolescent suicide attempters was an open trial that Dr. Kennard was talking about. So after 6 months, the attempt rate was 12%, and ours is 8.7%, so we're faring pretty well, and a fairly high amount completed treatment. So with Spark, we were able to fill a gap in available treatment for youth in our area, as evidenced by 386 people being enrolled over 2 years. It clearly shows that there's a need for this sort of service. And it's feasible with retention rates at 81% and measures looking promising. So I'm very briefly going to talk about a study we did within Spark. It's actually my dissertation study, and Lucas will later present. He's really taking this intervention to the next step. So I was interested in looking at what are the factors related to reduction in suicidal ideation over time with our adolescents enrolled in treatment. So we know there's lots of different risk factors for suicidality, anywhere from psychiatric diagnosis, substance abuse, previous attempt, hopelessness. It can be difficult to organize these factors in a way that helps move clinical and research forward. So in comes in the interpersonal theory of suicide, which seeks to remedy that problem. And the basic principle is that death by suicide occurs both when the individual has the desire to end their life, as evidenced by high levels of thwarted belongingness and perceived burdensomeness, but also the acquired capability to do so. So the thought, you'll see this diagram here with thwarted belongingness and perceived burdensomeness, is all other risk factors we think of, like hopelessness, low self-esteem, lack of social support, work their way through those cognitions, and those are most proximal, most close to suicidal ideation. For the sake of time, I'll just briefly mention, that thwarted belongingness is considered to be a dynamic psychological state, so malleable over time, and it's comprised of loneliness and absence of reciprocal care. And things like social withdrawal would be thought to be a reflection of that, according to Joyner's model. Perceived burdensomeness is also dynamic and comprised of liability and self-hate. And then acquired capability is probably the most novel component of this. So it's thought to be relatively static. It really doesn't change over time. And it's comprised of two facets: reduced fear of death and increased pain tolerance. And this is thought to develop through exposure to painful and provocative events, such as childhood trauma, previous attempt. Through these experiences, people are posited to acquire a capability for suicide. So in comes the study within Spark that we published the Journal of Suicide and Life-Threatening Behavior. We had 54 adolescents who, in addition to the measures we were already collecting, they completed the Interpersonal Needs Questionnaire. Was developed by Joyner and colleagues to really look at thwarted belongingness and perceived burdensomeness. And they also completed an acquired capability scale. So the first aim is really, are these states, as the model hypothesizes, is acquired capability really static over time? And can perceived burdensomeness and thwarted belongingness really change with treatment? And the second part is to see, okay, does suicidal ideation, when it changes over time, what is that? Is it depressive symptoms that's driving that change, or is it these interpersonal variables, perceived burdensomeness and thwarted belongingness? Because I think common wisdom would tell us we get the depression better, their suicidal ideation decreases, but this theory would say, okay, the thwarted belongingness and perceived burdensomeness are most proximal. So briefly here, we found that perceived burdensomeness and thwarted belongingness significantly decreased over treatment, and acquired capability stayed the same. So that's consistent with the theory that the interpersonal needs can shift and acquired capability is relatively static. Here's a nice visual representation. So thwarted belongingness, we found, changed at a more rapid rate compared to perceived burdensomeness. And Lucas will talk about that a little more in a little bit. And then lastly, to see how suicidal ideation changes over the course of treatment, we used a path analysis to see, did suicide risk change as a function of change in depressive symptoms or as a function of change in the interaction between these interpersonal cognitions of thwarted belongingness and perceived burdensomeness. So you'll see the solid lines with the asterisk show it was significant, less than 0.05. So we found that both change in depressive symptoms and changes in the interaction between perceived burdensomeness and thwarted belongingness both contributed unique prediction to suicide risk. So key findings from that is there's a significant drop following treatment in unmet personal needs but not in acquired capability. And both the change in the interaction between interpersonal needs and depressive symptoms contributed unique prediction to change in suicide risk. And really our takeaway is these unmet interpersonal needs, these cognitions are a really important target of treatment. So taking a step back, just to Spark in general, in regard to ongoing revisions and quality improvement, there'll be workbook revisions. We added a third group over the past year due to clinical demand. In 2015, we added a multifamily group based on the need for more family care, and that's been received well with higher client satisfaction with those receiving multifamily compared to those who did not receive it before. And then we've been working a bit on our clinical data to help us better inform our clinical care and evaluate our program. So we began to use REDCap, which is fantastic, no more data entry, and it helps us see what's going on in more real time. And we added some additional measures, including the Interpersonal Needs Questionnaire to look at these specific cognitions that might be tied to suicidal ideation, and the family assessment device to see if we're making changes in family functioning, and eventually to look if this is a key component to reducing suicidal ideation. Thank you.
Okay, next we have Lexi Moorhead, who is a research coordinator for the Pediatric Psychiatry Research Program at Children's and UT Southwestern. She's a study coordinator of the Suicide Prevention Skills Group program in a community setting, which she's going to talk about, which is based on the Spark program. And she received her BS from Spring Hill College and will be attending graduate school in the fall at UT Southwestern.
Morning. I will be speaking about the dissemination of the Spark program in a community health setting. I have no disclosures to report. And so I will begin by discussing the need for disseminating the suicide treatment to community settings. I will then identify the population in need of a suicide prevention program. I will discuss our study procedures and present our findings and how they informed the adaptation. And then I will discuss the next steps of the study. So we realized that access to services is particularly difficult for youth living in poverty. Youth living in poverty are twice as likely to have suicidal ideation and 4 times as likely to attempt suicide than youth not living in poverty. And more specifically, 1/3 of Hispanic children live in poverty and 1/8 live in deep poverty. Latino youth are more likely to engage in suicidal behavior and complete suicide than Black or non-Hispanic white youth. They're more likely to consider attempting suicide, more likely to have ideation with plan and intent, and they're more likely to make an attempt. So we also discovered that evidence-based treatments for Latinos are limited, especially for Latino youth. And one thing within our Spark program is the population is predominantly Caucasian, and so we wanted to work on expanding this program into a community health setting. So we started partnering with Metro Care Services, and Dallas Metro Care Services is the largest provider of mental health services to the uninsured and underinsured adolescents in Dallas. They serve more than 50,000 individuals each year, and over 4,000 of these patients are adolescents. And we conservatively estimate that over 400 of these adolescents have suicidal behavior, but currently at MetroCare, they have no specialty treatments for suicidal adolescents. Approximately 41% of these patients seen at MetroCare are Latino. So we completed a needs assessment through conducting and coding qualitative interviews with clinicians, adolescents, and parents of adolescents to discover what are their needs that are not currently being met at Dallas MetroCare. We found considerable support for creating a skills group for an augmentation to treatment with suicidal Latino youth. So this community pilot grant was a small grant from UT Southwestern, and it is composed of 3 phases. The first phase was the qualitative interviews, where we coded the interviews and then we adapted the Spark manual to fit this population. The second phase was pilot testing the intervention and training MetroCare clinicians in the intervention. And then the third phase is an open trial, and that's currently in progress. So the qualitative interviews, we interviewed 6 adolescents, 6 of their parents, and 8 of their clinicians. And we audio recorded, transcribed, and analyzed thematically, both inductively and deductively coded. So I'm going to go over some of the themes in the qualitative data analysis and then go a little bit more in depth with them. So we looked at the cultural and community norms, especially the gender differences and how those can impact treatment. We looked at the values within the community and how we can meet those values through this treatment program. We looked at the family and community acculturation and how the teens were acculturated, and especially how that compared to their parents. We looked at the family dynamics, as well as the response to depression and suicide from the community and from the family. We looked at knowledge, beliefs regarding depression and suicide, especially with the religious influence and how that impacts treatment. The stressors that are unique to this population, the barriers to treatment, more specifically how their low income status impacts their barriers to treatment, as well as social support. So barriers to treatment, many of them are ones you can expect, including a lack of transportation. Many of them had 1 car for their large family or no car at all. Unstable housing, unmet child care needs, lack of documentation and fear of deportation. And that also played a part in the parents' fear of children missing school due to truancy fears. And so we had to develop this intervention. Spark, we have groups that go during the day and the kids miss school. We're not capable of doing that with this group. And then there's also teen employment. So that was something we had to pay special attention to is that these kids were mostly employed. Some of the cultural beliefs and norms with the stigma that mental health was not discussed at home or with others. The religion, the belief that depression is a result of not actively practicing the family religion. This came up time and time again throughout our interviews with the parents and teens, but also with the clinicians and how they spoke about it. The gender roles, that mothers are typically more involved in the child's mental health treatment, but that fathers really had to approve a lot of the treatment that was going on, and we need to make sure the whole family is on board with the treatment. And then acculturation, that the parents and children differ in levels of acculturation, including values related to work ethic and views of mental illness and treatment. Here's some examples from our interviews. With the knowledge and beliefs, one of the children said, "My uncle says it's a demon, like the devil provoking my thoughts." That was something we saw quite a few times. Then a parent saying, "Pull yourself up, you don't have to feel that way," as a way to get out of depression. Barriers to treatment, the family may have 2 cars, but if they have 6 or 7 adults living at home, they're all sharing those cars to go to work. And then one child said at 4:15, her mom starts cooking dinner so it can be ready on time. So that was something interesting. We had to pay special attention to not holding these programs during dinner time. That was something really important to these families. And then some of the stressors, one clinician said, "Something I see among only my Latino population is that the parents are often Spanish speaking, and sometimes the teens don't really speak much Spanish, and so they have a communication barrier with their own parent." We actually saw this in our open pilot. We had a teen who spoke almost no Spanish, and her mom spoke almost no English. And so it was difficult communication just within their own family that we had to take into account. So some of the ways we adapted the manual, we realized right away that the intensive outpatient program is not feasible within this population. They are not capable of coming 9 hours a week or even 4 hours a week to these programs. We also realized we had to be able to create something similar to Spark, we needed to do a skills group. So we did this as an augmentation to their current treatment. So they're still seeing their therapist and their psychiatrist at MetroCare, but we are doing a Spark skills group that is 1 time a week for 1.5 hours for 8 weeks, and then a parent group that's every other week. We also had a little bit of content changes. So the parent group is primarily now focused on psychoeducation around depression and suicide and coping skills, and we've adapted the groups to include Spanish-speaking parents. So we have the ability to do both Spanish-speaking and English-speaking groups, which is something that at MetroCare was not currently done. They didn't have too many Spanish-speaking clinicians at the time. And then we also are trying to improve parent and teen communication by adding a family history project. And this is a project to help the parents and teens communicate about just their day-to-day and their reality. So we talk about, as a parent, what did you grow up in? How was your life? We hear a lot from the parents that they put a roof over their child's head, something they didn't have as a child. So the child has no reason to be depressed or suicidal. And so we're trying to combat that with just having an open line of communication about things that might not even be that stressful, favorite classes growing up, stuff like that. And the parents and teens have really enjoyed this project. So our outline of treatment, I'm not going to go over the ones for the teen because all of those skills are skills that we adapted from the Spark group. Some of them we had to shorten a little bit, but those are all of those. And then the parent groups, we go over psychoeducation, home safety, and mood monitoring. Mood monitoring is really special for this group too, as it doesn't require a lot of communication. You can really just say a number and say where your mood is on a continuum from 1 to 10. Communication, including validation, negotiation, and compromise. Then the family history project, and then at the end we do a big potluck and review of the skills, and the families really enjoy this aspect of bringing in food and having a way to kind of celebrate the end of it, but also communicate about what skills were important and what they enjoyed. So our next steps, we were just awarded a grant from Texas's Health and Human Services Commission to expand this program. We will have groups in all 4 MetroCare clinics, and we're expecting to reach about 250 adolescents and their families in a year. We will enroll any participant with suicidality regardless of race or ethnicity. A lot of the things we learned in our qualitative interviews were not specific to the Latino population. They were more specific to the low-income population, and so we think that this will be mostly seamless to expand it, while we will still have parent groups in English and Spanish. At this point, we have not run into the issue that any of the teens only speak Spanish, so we still conduct the child groups in English. We will account for race and ethnicity in the analyses as well. And then we also are going to train all of the MetroCare clinicians in the FISP, the Family Intervention for Suicide Prevention, by Dr. Jonas Sarno. And this is a brief suicide assessment and intervention. It includes the mood thermometer, the safety plan, and identifying strengths and positives. This is really important for this population because a lot of times the concern is that these children are only seen once. They come in for their initial assessment and they don't come back for follow-up. And so to have something that is just a brief intervention and a brief assessment will not only help the teen, but will also help the clinician feel a little bit more comfortable sending them home or determining what level of care is important. So the mood thermometer is used to rate, understand, and describe ranges of emotions and their associated behaviors and feelings. The safety plans, which MetroCare currently does a safety plan, we have one that we prefer that's one page so the teen takes it home and hopefully can take a picture of it on their phone or whatever they choose to do with it. But we're going to give them a little bit increased training in how to safety plan. And then we also have identifying strengths and positives, and this is where we end on helping the teens to identify some of the positives about their family and the strengths within their family, as well as asking the parent to identify strengths and positives within their teen. Here are my references, and we're going to skip questions for now. Thank you.
Okay, our last presentation is Lucas Zullo, who's a graduate student at the University of Texas Southwestern Medical Center Psychology Doctoral Program. His research interests focus on suicide prevention and presently utilizing the interpersonal psychological theory of suicide. The goal of his current research is to contribute to bridging the gap between theory and clinical interventions and apply the IPTS to real-life clinical settings. Lucas?
Morning, everyone. All right, so my talk is going to be on the first phase of my dissertation study, qualitative interviews to explore the construct of perceived burdensomeness among depressed and suicidal adolescents. And in terms of disclosures, this study has received funding from the Jerry M. Lewis Mental Health Research Foundation grant and the APA Dissertation Award. So the objectives for these next 15 minutes, I'm going to give you an overview of the interpersonal psychological theory of suicide, and then give a background on the importance of perceived burdensomeness and why we're choosing to focus on that construct. I'm going to present the study aims, the procedures, and then our results of the actual manifestation of perceived burdensomeness in the suicidal youth, and then the interventions that will be tested as a result of this qualitative interviews to be tested in a clinical trial. In terms of the interpersonal psychological theory of suicide, just to refresh from Dr. King's overview, there's thwarted belongingness, which is categorized as a psychologically painful mental state that results when the fundamental need for connectedness is unmet. So put more simply, it's feeling socially isolated, without reciprocal relationships, or maybe even being ostracized from peer groups. Perceived burdensomeness is a mental state characterized by the perception that one's death is worth more than one's life. So the idea that truly caring about a loved one may result in one committing suicide because they are such a burden on that person. This construct is broken down into two specific components. The belief that one is so flawed as to be an actual liability and a burden on others, and also a significant component of self-hatred. In terms of whether or not the IPTS is applicable to teens, there is initial validity in a clinical sample of an inpatient sample of teens who had recent suicide ideation or a suicide attempt. And in this study, it was shown that thwarted belongingness and perceived burdensomeness, which I'll abbreviate for TB and PB, were independently associated with current suicidal ideation. And in fact, the interaction did distinguish between passive and active suicidal ideation in this sample. So why focusing on perceived burdensomeness? In the study that Dr. King gave an overview of, we know that both PB and TB did decrease over the course of Spark treatment, except that the drop in PB was less than the drop in TB and explained more variance in suicidal ideation during the discharge measures. In addition, there has been a recent trend in the literature showing that in cross-sectional studies, perceived burdensomeness has shown a stronger relationship to suicidal ideation and past suicide attempts when compared against other variables, including thwarted belongingness. There have also been past qualitative studies looking at this construct as well. In a study with women with borderline personality disorder, the study authors noted a significant theme of making others better off by making a suicide attempt. In addition, there was a study using suicide notes left by members of the United States Air Force members who noted the significant themes of being a burden on others in about 32% of the notes examined. Now, in terms of previous interventions specifically targeting this construct, we noted only one, and that was by Ryan Hill, which was for his dissertation study. They created the LEAP online intervention. This intervention was administered to a community sample of adolescents who were pre-screened for high levels of perceived burdensomeness. This online intervention was about 20 minutes in length and was administered twice with a week delay between each administration. In terms of the actual modules that made up this treatment, there were 4. It was Learn, which was an orientation to the CBT model and what perceived burdensome was. Exploring their own cognitions of what they thought their thoughts of being a burden on others in their lives were, and assessing your options. So maybe other ways to think about this, the pretty basic thought challenging or coming up with other cognitions that could be testable hypotheses. And then planning, setting up behavioral experiments to go out and in real life and test those with interactions with other people. This treatment was successful in lowering perceived burdensomeness, but suicidal ideation did not drop at a significant level. In terms of this study, my overall dissertation study, the goal is to design new interventions to be implemented in the existing modules of the Spark IOP that specifically target perceived burdensomeness. And so phase 1, our qualitative interview is very similar to the previous presentation. Then phase 2 is going to be the clinical trial actually testing these interventions. Phase 1 has been completed, and I'll report on that today, and phase 2 is in progress now. In terms of the study procedures, very similar to the previous one, we interviewed graduates of the Spark IOP program, the teens, and their parents, and also clinicians who regularly work with depressed and suicidal adolescents. These interviews were audio recorded, transcribed, and then inductively and deductively coded. In terms of the questions asked, we had very broad questions asking teens, first of all, do you recognize this concept of being a burden to others? How does this relate to your thoughts about wanting to commit suicide? What makes these thoughts get worse? What makes these thoughts get better? What influence these thoughts? What have you done to manage these thoughts? So really getting at the broad different ways that this manifests with this population. We started off by asking the clinicians about this. We asked the teens and the parents in a very similar fashion. These interviews took about between 30 to 45 minutes to administer. And then the themes of these interviews are broken down here in looking at specifically identifying thoughts, feelings, and behaviors identified when teens have these thoughts of being a burden to others, and what strategies the clinicians already employ or any advice they have to us when we're trying to implement these interventions in terms of what has or has not worked for them in the past. And because our population is in Dallas, Texas, we did also look at spirituality. They are typically, teens have reported religious coping tools when in the Spark IOP program, and seeing that how related to perceived burdensomeness. So what we first looked at is the behavior. Most teens recognize that when they feel like a burden, they isolate. They pull back, because they don't want to burden others, they try to stay away from other people that they may be burdening emotionally or from a time perspective. There's also the opposite as well. Teens want to confirm that they are in fact not a burden. They reach out over and over again. Am I burdening you? Let me confirm this idea. Unfortunately, some clinicians have noted that this actually fulfills their hypothesis of potentially burdening their caregivers and burning out their caregivers. Clinicians know that this thought of being a burden has stopped teens from reaching out with their safety plans, has stopped them from coping effectively, and really gets in their way of utilizing healthy support systems. In terms of the cognitions, maps pretty nicely onto basic core beliefs of Teens are innately bad or damaged, they don't fit in, they always mess everything up, they're failures, they can't do anything right. These are all themes that occurred pretty frequently in these interviews with these teens. They really could not make the distinction between being unwanted, being a burden, and creating an inconvenience, which are really different categories. And one takeaway is that these thoughts of being a burden really waxed and waned with the depressive symptoms they were experiencing. If it was a good day, didn't feel as much of a burden. But if it was an especially bad day, maybe a lapse in the depressive symptoms, these thoughts of being a burden were more salient. And teens noted that they really mapped onto the wave of emotions that they were feeling. In terms of the parent opinion, parents regularly noted this is something that has come up with my teens because Spark is so intensive in terms of finances and in terms of the time commitment. These themes do come up maybe when they're driving the teen to the program. One parent I felt put it quite nicely. They said, being a burden is having to do something and not wanting to do it, which does not apply to caring for my child, versus something being hard and something you want to do and it is difficult, which they view as caring for their child and bringing them to Spark. Parents did become actually quite upset during the interviews when they noted that their teens did feel that they were thinking of themselves as a burden. And parents wanted ways to convey that even when, from an objective standpoint, this may in fact be an inconvenience to the parents, the benefits of caring for their child greatly outweigh the costs. And parents were asking us for what are some ways we can better address these thoughts with the teens. In terms of what makes perceived burdensome goes up, teens really worry about the financial cost of the Spark program. Even when they disclose their suicidal thoughts, now my parents are worrying about my thoughts. Now they have to make sure that I'm not going to make an attempt tonight. So making the parents be more concerned. Also, having parents fragilize their teens. When parents noticeably alter their behavior or tiptoe around their teens, teens become upset that caregivers are now having to influence their own behavior. When teens feel like they have to rely on the same support figures over and over, that they only have 2 or 3 people they can reach out to, they feel like they're burdening them. And when parents or siblings make comments about, give me a minute, I need a break, teens can really catastrophize and ruminate on those comments. What makes perceived burdensome goes down? Caring for others was our big takeaway. Being able to be a role model for other teens or friends. Many teens just said, helping out my friends with homework made me feel like I was contributing to the life of someone else. And when parents and family members recognize that teens are making progress and that they are getting better over the Spark treatment, they have felt that they're not as much of a burden. Also, connecting actions to values and values to actions, that they're acting in a way consistent with their values makes them feel, made their thoughts of self-hatred go down, that they are happy with the ways that they are acting. Making the distinction between the teen as a problem and having the teen as a problem in regards to being a burden is something that teens identified. And just direct communication around all these thoughts. Parents wanted more forums to express, I appreciate you coming to treatment and trying so hard. Just opening up those channels. Clinicians noted the very first thing is it's extremely difficult to tackle this problem head on. You can't argue a teen out of being a burden. And you have to be very careful to not invalidate when objectively they may be in fact burdening their parents from a financial or time component. Clinicians notice that when teens are able to contribute to others, this distracts them from their rumination and also gives them an objective piece of evidence to show that they are contributing to others. And just the more time that teens spend with their families, the more opportunities to gather this evidence they have. So a lot of behavioral activation and activity planning. Some quotes from the interviews, teens were very explicit in expressing the thoughts that they were a burden. One teen said, I don't know why you guys spend this much time. You know we definitely don't deserve all this. One parent noted she thought that she overheard me talking about how much this cost or whether my insurance was a thing, and she was asking me, am I worth this? And one takeaway from the parent interviews is one parent said, I haven't told her, but I've actually enjoyed this. I've enjoyed this pocket of time from her. Driving to and from Spark has given us time to bond. Obviously, this is not ideal circumstances, but this mother said, I'm enjoying this time I'm getting to spend with her, and I wish I could convey that to her. Clinicians said, our job as clinicians, we need to find new experiences and facilitate learning opportunities for them so they can gather more evidence to realize that this thought of being a burden, it may be a cognitive distortion. In terms of the actual manual adaptation using all this information, because perceived burdensomeness is split into the cognitions of self-hatred and being a liability, we conceptualize this as cognitions about the self and cognitions about others. So we were able to define the mechanisms of change as different for each component of being a burden. The mechanisms of change for cognitions about the self, we aim to increase opportunities to contributing to others, increasing a sense of mastery, and increasing the value of caring for oneself. And then for mechanisms of change for being a liability, focusing on the parents, focusing on the environment so that parents can increase that positive feedback to their teens and decreasing the negative feedback. And of course, addressing any cognitive distortions that may be around either one of these targets. In terms of the actual interventions that we created and are now testing, these are the lists for the self-hatred component. The first one, I don't know if anyone has seen the movie Pay It Forward, but really going into the idea of random acts of kindness, the ripple effect. Even a small act such as holding the door for someone can really make someone's day, and really trying to impart teens that you can start small and then build up to greater activity scheduling. Thanks notes to parents. This was adapted from Jonah Sarno's study at UCLA, the safety intervention, which are regular thanks notes from the teen to the parent and from the clinicians to the teens and from the parents to the teens, opening up the channel of communication and acknowledging ways that they're contributing to the teen's life on a regular basis and vice versa. Good deed for, the note to incoming teens. For teens on their last day for the graduation ceremony, they're able to write a note to the new teens, welcoming them to Spark and giving them advice on what are some helpful tools and skills for them. Good deed for self and others. Every single Spark group, we asked teens to identify what's one good thing you did for yourself and for someone else. Being able to couch that as when you're depressed is really hard to engage in self-care, and it's also really easy to forget when you're helping other people. So let's be sure to note that every single day you come in. And if you can't think of something, let's schedule something together. Values identification and activity planning, taken right out of the ACT and behavioral activation literature, showing that valued action is extremely important when targeting thoughts about the self. And then a scale diagram that we created just for this intervention, having an actual physical scale. Teens are able to fill in on one side ways that they're burdening others, ways that they're inconveniencing others, and ways that they're contributing and helping others. And asking teens which weighs more. And we teach this at the same time as the cognitive distortions module to see what unhelpful thinking styles may be going on here to weigh the scales one way or another. And we can also add to the scale of ways we can contribute to others. So we're really in control of this situation. In terms of being a liability, parent psychoeducation is huge. We sit down with parents. What does PB look like for your teen? How does it manifest with your teen? What are some ways we can validate when the teen expresses these thoughts? The thanks notes, again, we have parents write them every single week to the teen and coach them. So what are some helpful ways to phrase the thanks notes? So positive instead of negative reinforcement. Letter from the parents. At the halfway point of the Spark program, we have parents write the teens a note saying, we're so happy that you're making progress. We're really happy that you've gotten better and that this is really a worthwhile investment for us. So giving the teens that, many teens put that in their hope kit as something that they can look back on. And then goodbye notes to teen. On the last day for teens, all the other teens in the teen group write a letter to the teens noting one way that they contributed to the Spark group, one thing that they appreciated them, and that the teens are able to take with them on their last day. And then once more, the scale diagram for any thoughts of being a liability. In terms of next steps, we're currently conducting the clinical trial, testing TAU, the standard Spark program, against TAU plus these PB-specific interventions, and we're aiming to finish in the spring. And that the trial does produce significant results, these new interventions will be added to standard care in Spark. And that's it.
Thank you, Lucas. It's now my pleasure to introduce our discussant, Dr. David Brandt, who's currently the Academic Chief of Child and Adolescent Psychiatry at Western Psych and Clinic and Professor of Psychiatry, Pediatrics, and Epidemiology at the University of Pittsburgh School of Medicine, and he holds an endowed chair in suicide studies. He, as we discussed earlier, he co-founded and now directs the Services for Teens at Risk, which is a suicide prevention program, also providing education professionals in the treatment of at-risk youth and their families. Dr. Brandt's a member of the National Academy of Medicine and is being recognized for his research by the American Academy of Child and Adolescent Psychiatry, the American Psychiatric Association, and the American Foundation for Suicide Prevention, and NARSAD. His work is focused on the identification of risk factors for adolescent depression and suicidal behavior, and on the translation of those findings into clinical interventions. Dr. Brandt and his colleagues have endeavored to understand possible intermediate phenotypes of suicidal behavior and mechanisms by which suicidal behavior is transmitted from parent to child. Welcome to Dr. Brandt. Thank you for being here.
It's an interesting ladder there. I guess that's a barrier to implementation. Well, thank you. First, I'd like to compliment your group, Betsy, on 5 things. I think that you show a lot of qualities of what we look for in a learning healthcare system. You have self-study. You had a really nice use of qualitative data in terms of trying to understand the phenomena rather than just moving in as if you assume that you know what was going on. You're trying to identify mechanisms, which then are the active ingredients that you may want to disseminate. I thought you were very active in trying to understand barriers. And then you take that information and try and develop or modify interventions. So I'd like to speak about each of the 4 presentations with regard to 3 things. First, what's the active ingredient? Second, what's the barriers to implementation? And the third is what might be things that would facilitate its implementation in the community. So with regard to ASAP, which I know pretty well because we've worked together on it for the last few years, we still don't know what the active ingredients are. You know, it could be the app, it could be some aspect of distress tolerance, but I think it's really important to understand that because it's still a pretty, even though it's brief, it's still a pretty complex and multifaceted intervention. And the fact is that I'm not even sure that if you're going to do this on an inpatient unit, that most people have the time or capability working there to do a chain analysis. And there may be, so I think we need to try and figure out if there's some shortcuts that then could be something that could be done in a standard way. In terms of things that may facilitate uptake, we need to understand why we weren't able to engage families that well. And especially in contrast to the really nice job that your group did with the IOP in terms of engaging families. If we really think this is such an important active ingredient, what is it that we could do to engage people better? And then with regard to the IOP, one thing I wasn't clear about is whether you have rolling admission or whether, so I think that's a challenge insofar as many of the models that you present are sequential. Yet, if people are coming in at all different times, how do you make sure that people get, get the whole picture and get the benefit? And again, I think the IOP is quite a multifaceted and very complex set of interventions, and it would be good to try and understand what are the active ingredients, because if we're going to disseminate that, it's probably not, there probably are some things that are more important than others. And we've been involved, actually the first place that we were able to disseminate the IOP at START was in Beirut, believe it or not. One of our colleagues moved back to Lebanon, and he runs a child psychiatry program there. But the program has been replicated now in Seoul in South Korea. And they have interesting problems because it's not so much that youth are employed, but they actually take school a lot more seriously than we do in the United States. and they don't have the time to devote to the IOP. And so I think that this issue of the cultural adaptation is a really, was really important, and I thought it was a very useful work that you did in talking about how you might implement this in families that are Latino. And you spent a lot of time focusing about the interpersonal theory of suicide, and what I would say about that is I thought that the work on, for example, on perceived burdensomeness is quite interesting and useful, but at the same time you're now adding additional levels of complexity to the intervention, and you wonder whether you can take a step back and identify what are some simpler, kind of meta interventions rather than layering on additional techniques and to an already very complicated intervention. So on the one hand, I think useful to think about and important. On the other hand, the way that it's going to be delivered, you may want some organizing principles that are simpler to teach and implement. The other thing about the interpersonal theory, I would say, is that it runs counter to what we know about what are the main motivations for self-harm and suicidal behavior in kids, which is to relieve internal distress. That the interpersonal factors are important, but they aren't paramount. And the idea of internal pain is kind of inferred and secondary. Lucas did speak about that, but it was kind of embedded in the theory. So I think that the problem is that it does lead you to focus on something that's important, but not necessarily central for many people. And the other aspect about it is that the acquired capability is that the thwarted belongingness and perceived burdensomeness, I think, are pretty easy to articulate. But the acquired capability is something that I think most people have had much more difficulty generalizing about and understanding, and it ranges from being traumatized and taking more risks to buying a gun. And so I think that just speaks to that you don't want to get locked into a theory that limits you and then keeps you from exploring other aspects that may actually be more active and important for helping these kids. So, and then a couple of other things I would ask that you might want to consider is to try to, as we're thinking about the active ingredient, what is it about the safety plan that really is helpful? There now is some evidence that if you teach people safety planning, it does seem to reduce suicide attempts. Barbara Stanley recently published a paper on that. But what is it about the safety plan that's helpful? Because that's what we really need to be doing. And the other thing is that we haven't really talked about the impact on access to lethal agents as part of what it is that all these programs are doing. And so I would urge you to consider assessing that as an outcome or an intermediate outcome, because we know that the same degree of suicidality, if you have a loaded gun in the house, can have a really different outcome than if you don't. And I think just in the interest of time and to allow people to ask questions, I think that concludes my remarks. Thanks. I think that people probably have questions for these great presenters. Can you go to the mic, please? Oh, well, I'm glad you got comfortable. Thanks.
So I know you talked about the Spark program and the program with the Latino youth. You talked about depression and suicidal ideation, other outcomes. Did you measure any other psychosocial outcomes, like improvement with academics or other things outside of just the ideation and the depression?
We recently added a measure of family functioning to see if that's changing. I'm trying to think of any other key.
So we have measures of, with the suicide, the CSSRS, and suicidal ideation. We also have depression outcomes. We have clinician-rated measures of school, some of the triggers. We don't have, it's a very good point. You know, we don't have like actual attendance. We get that at baseline, but we're not measuring it over time.
Okay. Anything on exposure to abuse or community violence?
Yes.
Okay.
Yeah.
And then one last,
baseline.
sorry, go ahead.
No, go ahead.
And then my last question is, did you document the parents' potential previous histories of suicidality or suicidality in the home?
Can you say that again?
I was wondering if you had documented whether the parent had experienced their
yes, we
own
do.
suicide
Yes.
attempt or
Yes,
self-harm.
We do. We measure that. We document exposure to suicide and family history of suicide, yes.
Great. Thank you. Thanks.
Good morning. Really nice presentations. So I'm actually not sure who this question is best meant for. A lot of the programs that you discussed require some intensive involvement from the kids and the parents, which is appropriate. Sometimes when I'm wearing my clinical hat and I want to make a referral to that kind of program, I get reticence because parents and kids can get a little scared off that it's so involved. And I wonder, and you spoke about this a little bit with some of the barriers, I wonder if you have any specific efforts at engagement, or if you can talk about anything in that way.
I can definitely relate with what you are saying. Committing to an IOP is quite a big commitment, anywhere from 7 to 10 hours a week. Personally, once we get a referral, we have a care coordinator who does an excellent job really explaining the program in depth and seeing if that's something the family's willing to commit to. And then when I have a family in my office, often the teen can be the one who's a little reticent. So kind of a foot in the door technique, you know, let's try a couple groups and see how it goes. 90% of the time, in my personal experience, it's pretty acceptable, and we tend to retain people once they begin.
There was one thing I forgot to say that I think relates to some aspect of the question, which is in Lucas's presentation, he talked about the idea of people doing for others. And I'm just wondering, as people go through the IOP, you are actually training cadres of parents and kids who potentially could be navigators for subsequent families. And I just wonder if you've given thought to that, because I think that would be a useful byproduct. It would allow people to give back, and I think it would provide some validation in terms of, like, you know, was it really worth investing this much time in this program?
I agree with that point, and it was one of the suggestions I was going to make, is when we look at some of the things that are done in the addictions community, one of the things about engaging families, which has always been extremely difficult with families of persons with addictions, was to stop using the term enabler. Because of course it has all those negative tones to it, and it is blaming the family for trying to survive around a person with an addiction. So they've now gone to using the term manager, because that person who's keeping the family going while they have a person with addictions destroying many processes has changed how families become engaged. And I also, that's really more of a comment or a suggestion of how we treat families. I don't know what the process is when you bring them in, but the other suggestions, you had started that with using some of the suicide survivors as mentors within the schools. And I don't know if you go to the schools or go to the homes with any one of the visits to try and capture the families by not just having them always come to the center, because there are many barriers for a lot of our families in going to a center. I mean, the barriers are phenomenal. And if you start to look at some of those barriers and then create the survivors to help capture and case manage other students in the school before they require acute hospitalization. And thank you for bringing up this very needed topic.
I just had a quick question. You mentioned this program that one of the limitations throughout the presentation was the cost of the program. And so I was just wondering, what was the cost of the program? Are there subsidies? And kind of just access regarding price.
Yeah. So as many of you all know, insurance can be very complex. So I can speak to Spark. We do accept Medicaid. That's a more recent happening, and we accept private insurance. But as you all know, that can vary so widely what people's copays are or deductibles are, and sometimes the cost, unfortunately, can be quite high.
And sometimes we have, in some cases, adapted the program where the IOP is prohibitive, so that we have them come in. Again, depending on if they can take a lower level of care, we have the skills taught in an individual format, or use more trainees or other people to help with that, because we really, our goal is to try to give these kids the skills and try to adapt it to whatever needs they have.
Great presentations, really interesting. So as a former clinician myself, I'm always kind of thinking about the clinicians. I'm wondering if I have two questions about clinicians. First, whether or not you had assessed any clinician level variables to look at variability in delivery of care, and maybe patients' responsiveness to those particular clinicians, anything that is going particularly well.
That is a great question, and we've really just started to implement in this Spark program some QA measures, and we've developed some rating scales for different group, the individual components as well as some group process skills. So we have not analyzed that data or looked at that, but it's a very good point, because we have different levels of people that are doing the different groups, and as well as different styles, and so trying to look at that. And we also have what we didn't talk as a weekly consultation group where we talk to the therapist, we talk about the different cases, and we talk about different ways people handle the different problems that come up to try to kind of calibrate some. But that was our concern, is that there may be obviously there are differences in therapists, but there may be drift now that we have 3 groups. So
Sure.
that's why we implemented the QA.
Yeah, that was related to my next question, was your organizational context and supports that you're giving your clinicians and how you help them to continue to grow. And this is always a thing with, with evidence-based treatment, is helping people to really make it, can remain, with fidelity to the model, but make it their own and breathe life into it and really be able to connect with patients. So I was just curious about how you do that, but you have consultation groups, so.
Yes.
Yeah.
We actually meet twice a week. 1 is to go over the patients, and then 2 is for the therapists that are running the groups to discuss issues and problems and cases and
Okay,
management. Yeah.
Thanks.
Thank you.